Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and Speech Therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome everyone. My name is Renee Garrett and I'm your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Julie Sullivan is a paid employee of Brigham and Women's Hospital, where she serves as the program manager of the COVID Recovery Center. For her podcast guest appearance, she receives an honorarium from SpeechTherapyPD.com. Her non-financial disclosure is that she's serving a 5-year term as a committee member of the U.S. Agency for Healthcare Research and Quality, AHRQ, on the Long COVID Care Network. My financial disclosure is that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia. As the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on SpeechTherapyPD.com, I do receive financial compensation. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Questions can be written in the chat or the Q&A box tonight and will be answered throughout the presentation. Now, without further ado, we welcome our guest, Julie Sullivan, MS, CCC-SLP. Julie is the program manager of the COVID Recovery Center at Brigham and Women's Hospital in Boston, Massachusetts. The COVID Recovery Center is an innovative, multidisciplinary clinic serving the needs of patients with post-acute sequelae of COVID-19 or PASC. As program manager of the COVID Recovery Center, Julie serves as the primary liaison for both patients and healthcare professionals seeking guidance and treatment for long-term COVID-19. Her role includes coordinating care for a cohort of 4,000 patients, providing symptom-specific resources to long COVID patients, and fostering a community for individuals experiencing long COVID to share coping strategies. Julie's background is in speech-language pathology, where she worked in subacute rehab, neuro rehab, and skilled nursing. She served as a director of rehabilitation for outpatient and skilled nursing facilities and as an adjunct instructor at Northeastern University, teaching graduate and undergraduate courses in speech-language pathology. She also worked as a state surveyor conducting health and safety surveys of Medicare-accredited skilled nursing facilities. Welcome, Julie. Thank you so much for being on the podcast.
Thank you so much for having me. I appreciate the invitation.
Yeah, of course. So let's kind of jump right in. I think a really important place is maybe to start by sort of defining long COVID and maybe dispelling some myths, which may take a little bit of time to kind of do that twofold part. But how would you say, I don't think there's a quick and simple definition of long COVID, but maybe kind of give us the short version and then we can go from there.
Sure. And that's been a lot of the work because it is a novel illness to define and define COVID by its symptoms. And there's been a couple of new working definitions that have come out. So long COVID is a complex neuroimmune condition that can impact all body systems. It's a result of acute COVID. It's usually a result research is still trying to figure out, but they suspect that the body's not able to completely clear the COVID virus, and there's an ongoing inflammatory and immune response. This inflammatory response can manifest in a few ways. There's a number of symptoms. The most common symptoms are profound fatigue and post-exertional malaise. Post-exertional malaise is a crash that people experience after too much activity, and it's different from fatigue where you feel tired. This is really a whole body response and energy depletion. People will have an exacerbation of brain fog and other symptoms and may run a fever when that happens. Cognitive dysfunction and brain fog are another common symptom of long COVID, and that includes memory loss, word finding difficulties, and difficulties with complex attention and executive functioning. People can also experience heart palpitations, shortness of breath, new allergies, recurrent illnesses, headaches, pins and needles and paresthesias. So it can really impact each body system. And so the most prevalent symptoms, I would say, are the fatigue and the brain fog. And then there's a host of other things depending on the severity and the type the person has.
Yeah, and I will say, as someone who's had COVID a couple of times, I definitely had that both times. Not fun when you try to work and teach and host a podcast. It does make challenge, and for us, I think as professionals, we've been used to being in an environment where maybe we were exposed to things like that, and so for us to be able to go in and function when the fatigue in particular and the cognitive kind of fog, because that's a great way of describing it, last for not like the duration of the illness, but it lasts for a while afterwards.
Yeah, and it's puzzling to not bounce back and to not feel better. And I think our inclination is to jump back into work and regular activities, but that actually does more harm, and that can exacerbate and prolong long COVID symptoms if you do too much activity. So that's another complicated factor.
Wow. So let's talk about some myths, because I'm going to pick on my husband because he can't hear me. He was talking about this earlier, and he said he really just thinks people are sick of talking about it and sick of hearing about it. But I was kind of sharing with him what you and I've talked about before, and how if we don't talk about it, then we're not getting good data and we're not getting good outcomes for these patients who are having these differences in what we would consider like a typical course of recovery versus this long COVID.
Right. And I think that's a big myth, is that people don't understand it because they haven't experienced it. And if we've learned anything from COVID infections, it's very individual how everyone's body responds. And we certainly saw that at the beginning of the pandemic, where some people who contract COVID go into respiratory failure and die. And some people are very ill for a very long time, and others recover nicely after a few days, and some people never have symptoms. And so that's hard for people who are experiencing long COVID, because I think everybody tends to judge long COVID by their own experience, which is not the case at all. And, pretty much without fail, each person that I talk to with long COVID, they are the only person that they know with long COVID. And they've been to a lot of doctors who have said, your labs look fine, you should be better by now. Maybe you need to see a psychiatrist, maybe it's anxiety. And so it's really common to have these physical symptoms dismissed as being anxiety and depression. And that's very frustrating for people living with this condition.
Yeah, and it doesn't, necessarily pick an age, right? It's across the lifespan that we're seeing it.
The average age in our clinic is 48 years old. So this is very much an illness that affects the productive members of society. These are people who are working full-time, raising families, socializing, very active. Many of them were elite athletes, and it completely derails their life. It's less common in children, although now there's been a couple of new research studies that have come out in the past couple of weeks indicating that it's more prevalent than people think, and it's not being identified as much in children, and that needs to be addressed as well. But the incidence, they conservatively 6 to 7% of people have long COVID, which is still millions of people in America and 400 million people around the world. And, I'll tell you, our clinic has been in practice since 2021, early 2021, and we have continued cases. We're still getting a high volume of referrals every month, and it's not slowed down. And so people are continuing to get long COVID, even being vaccinated, and with each variant, it's still happening.
Yeah, and that it's just kind of astounding to think of the numbers. And I shared with you earlier that I worked in acute care the entire, the first 3 years up until 23 of the pandemic. And, I was kind of in the worst of the worst. I was in the most remote and rural hospital where we had the highest numbers of regionally, there are 5 hospitals in our health system, and we had the highest numbers consistently throughout because of not only the location that we serve, but the volume of long-term care facilities that were also involved, that people got, like you mentioned, got sick and died pretty rapidly. We had several volunteers in our hospital that had, were geriatric and got sick pretty early on and passed away. And so the exposure level was definitely there on a daily basis for 3 whole years. And I never got sick. And I'm very grateful for that. I'll be one of those weird people that says elderberry syrup. I'm a fan. I did it every day.
Yes.
So I'm not going to say that that's what saved me, but I definitely was in the thick of it in ICU. And, we had overflow from the COVID unit into, at some point we had it basically all throughout the hospital. They stopped using strictly COVID units, and just whoever got admitted wherever they could put them is kind of how it transpired. And so it was everywhere. It wasn't just isolated to ICU or isolated to the COVID unit. And so I think that it's an important point to make, because we're back now. We're back in person at work. We're back in our communities. Traffic is certainly reflective of that. And, I still see people who mask in grocery stores and things like that for whatever reason. And I think that's another good point to make, is that there's still a lot of people who make a lot of judgment calls in public about people who are still masking, but we don't have any knowledge to know why they're masking. Maybe there's someone who's had, an autoimmune disease, or they have had cancer or something like that, where they may have some kidney issues where they're on dialysis consistently. And, I think that's another good point to talk about people who are immunocompromised and the risk factors that they face that could be modified.
Right. And the stigma of masking is really hard. And I think ultimately what also a lot of people learned during the pandemic is, hey, maybe I don't have to catch a cold or a flu or a stomach bug every time I travel, so I want to wear a mask in high risk areas, and I want to protect myself. And so I think it needs to be normalized a bit more. It's discouraging how we were all masked for so long, and now it's turned away from that. And I think people need to be comfortable wearing a mask when they feel that they might be at risk, or they feel that they're coming down with something. We have to normalize that option.
Yeah, no, I'm going to Seattle for ASHA in December, and I can't promise you that it's a long flight. I'm going to be flying across country, and I tend to be that person who always has the person behind them who coughs even prior to the pandemic.
Right.
So I'm like, you know what? If you're behind me and you're coughing, that's it for you. I'm gonna spray you with Lysol and a mask.
Yep.
So Joni says, I'm asked because I started breast cancer this year and have asthma. I've never had COVID and I fly a lot. Well, you know what, Joni, hats off to you for not having it, because I've had it at least twice, and I think that's possibly what happened to me in the spring, even though I tested negative. And we can kind of talk about that at the end if we need to fill some time.
Yeah,
but
but
I
I think
think
Joni's point is good, that you take precautions and you can avoid contracting COVID. And there are so many people who are immune compromised among us, and we don't know who they are. And I think that's another good reason to protect yourself and to protect other people in crowded environments. And to
Well, and even
test when you're tested, when you feel cold, when you feel any symptoms, and stay home when you're sick, and all of those things that are just kind of good medical etiquette, I think in general, that we need to maintain.
yeah, and now that I'm doing consultative work, I'm in a lot of group home environments, a lot of day support programs, and even some of the clients' homes who have lived with caregivers that may be family members. A lot of them will ask me to either mask or ask if I've had a known exposure, and it doesn't bother me, but I know other people, they get kind of offended by that. And again, I don't know what the last time it happened, I don't know what the lady's medical history was. She just wanted to make sure she was protecting herself and her family. It's her home, not mine,
Yeah,
you
and as
know.
medical professionals, I think we need to be extra sensitive to that. And, to if we're dealing with someone who's ill, they don't know where we've been. We need to mask or offer to mask, and unless they say otherwise.
Yeah, I agree. Any other myths that we can kind of touch on or dispel about long COVID?
I think one of the big myths that people describe is people telling them that this is in their head, that it's due
Mhm.
to anxiety, and they need to snap out of it. And
Snap out of it. That's a good one.
yep, and I can tell you, no one's ever gotten over long COVID by snapping out of it, and so that's really not helpful. And I think an important point, and they hear it from medical providers as well, is just because we don't understand something fully yet doesn't mean that it doesn't exist. And so I think that's what we really encourage medical providers to remember, is this is a completely novel virus, and this is a novel post-viral illness. And because you can't see it from the outside, and because basic lab tests may not pick up on it, doesn't mean that it's not real. And it's okay to say, I don't know much about long COVID. I don't know what to tell you. But the important thing to tell people with long COVID is, I believe you.
Hmm.
That these are people who are legitimately sick, and not looking for medical attention, and not malingering or anything like that. These are people whose lives have been really disrupted. And so I think that's a discouraging myth, is that these people are somehow faking it, or it's due to anxiety, or they don't want to go back to work, or any reason like that.
Well, I think it's very similar to people who have experienced PTSD and being told they should snap out of it, or, it's been a while since that happened to you. You should be over it by now. It's really not good practice for anyone.
I wouldn't tell someone with diabetes to get over it, or someone with cancer to get over it. So
Yeah, but again, I don't think people think of it in those terms, especially when we know that the mental illness component may be part of it. Maybe for some people it's not, but for some people it is. And it's just so, I don't know, it's so dismissing. And it certainly probably for the patient doesn't feel like, one, they're being supported, but two, that they're being listened to. And we know that that can lead to things like withdrawal, not just from medical treatment, but from their life, their family life, their places a bit higher risk for things like depression. So it's a sort of full circle moment where if we're doing that, we're exacerbating the feelings that they're already experiencing, because they're probably really scared. They don't know what's happening. We
right,
don't sometimes know what's happening as medical professionals. So,
they've waited a
um,
long time for these appointments, and then to be told maybe you need to relax a little bit is just not helpful at all. And so a lot more work needs to be done to educate primary care providers to talk about long COVID with their patients who have COVID, to let them know what the symptoms are, and to ask the right questions. If someone comes in and says, yeah, I had COVID a couple of months ago and I'm still exhausted, to not say, well, you'll get better. Probe a little bit deeper, ask further questions, and see if it warrants a referral to a long COVID specialist.
so SanFam says, does the amount of time you have had COVID-19 affect how severe the long-term symptoms will affect you in the future?
That's a great question. The short answer is yes. And so your risk for developing long COVID increases with each COVID infection. And so we certainly have plenty of people in our clinic who are now on their third or fourth COVID infection. They did okay and recovered the first few times, and now they have long COVID. And so definitely the risk increases with each infection.
And thinking about what role we play as SLPs, because I know when I was working in outpatient was vastly different than when I was working in acute. When I was in acute, by the time we got to the end of the third year, every patient who coughed got a swallow eval order. And I was just like, oh my God, seriously? Because for some people, they did have true dysphagia, but for other people, it was like, okay, they coughed because they have COVID. I coughed when I had COVID and it wasn't related to eating. So that was one thing. And then in the outpatient setting, I was definitely seeing more of this long COVID, like you mentioned, the cognitive deficits that were persistent. And these, some of them were well, they were all interesting, but there were a couple that really stood out for me because they were patients who had been diagnosed with dementias, but that's not what it was. And you know, you can kind of, if you've worked with the population, you see it, you know what that looks like. So can you talk about that a little bit?
Yes. And so the cognitive symptoms from long COVID, I think would mimic most post-concussive syndrome or mild traumatic brain
Mhm.
injury. So difficulty with complex attention, being easily overstimulated with information and sensory information, difficulties with executive functioning and processing complex information, short-term and working memory, word retrieval. Where it diverges a little bit is that unlike post-concussive syndrome, these folks also have debilitating fatigue. There's disruption of their autonomic nervous system, which we can chat a little bit more, but that keeps their brain in fight or flight. And so their brain is essentially being bathed in adrenaline and cortisol, and that can cause anxiety and depression, and exacerbate their cognitive symptoms. There's also the psychological component of not knowing what the prognosis is going to be for themselves. Is it going to get better? Am I always going to be like this? Am I at risk for developing dementia because of this, or Parkinson's, or any other neurodegenerative disease? And the answer is we don't know yet. And
Mhm.
that's hard to hear when you're 46 and have 3 kids and are working as a full-time teacher. So there's a lot of, I think, emotional support that SLPs are really uniquely good at providing, as well as cognitive strategies, and then understanding how fatigue plays a role. And in long COVID, fatigue is triggered not only by physical activity, but by cognitive load, emotional stress, and sensory overstimulation. And so it's often a balance of teaching people to recognize those triggers and to really pace themselves. Use the spoon theory, which says, you get 10 spoons a day, and how do you want to spend them? And dole them out. And once the spoons are gone, they're gone. So if you have something big, coming on that is cognitive, then you don't want to walk 3 miles that day, and you don't want to have that difficult phone conversation before, and things like that. And so it's a lot of restructuring the day. And I think also supporting people with living with a chronic illness,
Mhm.
because that's essentially what it is at this point. So living with a chronic illness that is poorly understood and not taken seriously by a lot of the general population. And so how do you manage maintaining the roles that you have to maintain with that? So SLPs are really helpful in that regard.
Yeah, I had someone who was in their 80s who was, for all intents and purposes, functioning and living independently prior to her bout with COVID. And a lot of people would say in our clinic, "Oh, she's got dementia," but the components were exactly as you described. It was fatigue throughout the day. It was more reliance on visual aids to make sure she got her appointment times and where she was supposed to be within the clinic correct, because she was someone who was driving before, living independently,
Mhm.
grocery shopping. She'd been retired for several years, but very active in the community, active in her church. And all of those things became incredibly difficult for her. And that's really, what everybody just said, "Oh, she's got dementia. She's 82." And I'm like, it didn't even present that way, because the things that she remembered things, it wasn't that, it was the stamina for her to be able to complete tasks like paying her own bills,
Mhm.
managing driving a car to go to the grocery store. I'm teaching a TBI. It's interesting that you said post concussion syndrome, because I'm teaching a TBI class this fall. And one of the things I told my students this morning was that, again, those cognitive tasks that we take for granted, like getting up and brushing your teeth and making coffee and eating breakfast, getting dressed,
Mhm.
logging into Zoom for your class or whatever, we sort of get on autopilot, right? We're doing those things all the time. And so it seems easy. driving to work. Sometimes we kind of, depending on where you live and what your traffic situation is, you might zone out and autopilot because you know the route you're taking. It's what you do all the time. And those are the things that we see when executive function comes into play that are more challenging for this population. Is that what that's kind of what you're going for and what you're seeing as well?
And I think with the age group that we're working with as well, like I said, these are folks who are, so in many cases, the sole breadwinner of the family, and their jobs are complex. And so, you know, with the fatigue and the uncertainty of how they're going to feel day to day, it's challenging. And then also, you know, trying to come up with work accommodations, because a lot of these jobs, it won't be helpful to reduce the hours because the complexity of the job is the complexity of the job. You know, it's not like you could just clock in for fewer hours and take a rest. It's a you know, a program that they have to manage and a project that they're working on. And so helping them break down those tasks to see what they can do, what they can't, and then what accommodations they can reasonably ask for is also part of treatment.
Yeah, and I had a colleague who is also an SLP, and her sister wound up in our hospital system, and she had long COVID. And she did just a little case study for a talk I did in Mississippi a couple years ago on this, and she really wanted to share how much difficulty she had with recall of her hospital stay and that immediate, probably month to 6 weeks prior to her discharge. She was in the hospital for probably about 2 weeks, went skilled nursing for, I want to say, probably 3 weeks. And when I interviewed her, it was about a year post. And that was the thing that really stuck out for her, was that she couldn't really outline things that happened in the hospital with accuracy. Like, she could remember the general picture. And I think, you know, when you're talking about relating that back to patients that have had a post-concussion type syndrome or a mild TBI, it makes total sense when you're thinking about hypoxia. It makes total sense. When your brain is deprived of oxygen, it's not going to function afterwards the way that it did before. And so are there studies coming out or being done to look at that?
Are you taking advantage of our new amazing feature? The certificate tracker. The free CE tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider, speechtherapypd.com.
Yeah, there are a lot. It's an extremely active area of research right now, and there's a couple of interesting things that have come up neurologically in studies. One is that a research team out of Derry, England, found that there is leaking in the blood-brain barrier, and that is not typical with other illnesses or other viruses. So COVID can actually cross the blood-brain barrier and be in the brain itself, which causes its own host of problems. They're also looking at microglial activation as being implicated. It's related as well to POTS and chronic fatigue, which also result in brain fog. So it's a very active area of research, both within Recover, which is the National Institutes of Health Research Initiative, that is a federal initiative to understand long COVID, as well as some really good private organizations. One of them is PolyBio, and that's a consortium of researchers and scientists, and it's privately funded. And they're doing some amazing work at immune profiling and neurological imaging and using very high level MRIs and PETs to try to understand how COVID stays in the brain and what it's doing to the brain. We're also finding some interesting things with hypoxia. I'm glad you brought that up, because the other thing that long COVID does is, well, just to give you a little basis for what we think is going on with long COVID, there's a couple of different things that COVID is doing. One is that the virus is persisting in the bodies of people with long COVID. It might persist in our bodies as well, but our immune system is able to keep it in check. For people with long COVID, the viral remnants cause an ongoing inflammatory and immune effect. which disrupts the lining of the cells. It causes vascular inflammation, and that interferes with the body's ability to take in oxygen and convert it to energy. So that's an interesting study. It also can reactivate latent viruses. So people who have had Epstein-Barr virus, which causes mono, are at high risk for developing long COVID and for reactivating mono. And Epstein-Barr is another interesting virus because we've all been exposed to it. We all have antibodies against Epstein-Barr, but not many of us have had mono. And so our immune system is able to keep it in check. And it's a similar process maybe for COVID. So COVID can reactivate Epstein-Barr virus, cytomegalovirus, and a couple of others. It can cause microclots. And there was a question for a while about microclots, whether microclots were causing the problem or microclots were resulting from inflammation. And a study, really interesting study, came out last week that showed that it is microclots themselves related to the fibrin in our body. It's part of our immune system that causes the clotting. And so that's another etiology for it. So all of these things interfere with oxygen exchange, and that causes dysautonomia and POTS. And those are two of the big symptom clusters associated with long COVID, and they can be very disruptive. It causes orthostatic changes and shortness of breath and exercise intolerance and dizziness and headaches and brain fog. And then it also causes chronic fatigue, myalgic encephalitis. And that has been another poorly understood condition that they always suspected was post-viral, but didn't do a lot of research into it. And so now, thanks to long COVID, the ME/CFS community is really getting better research and treatment to understanding what's going on there as well. We've got some interesting doctors and researchers at through Mass General Brigham. And one of our doctors, David Systrom, has been studying chronic fatigue for many years and has detected, using a very high level cardiopulmonary exercise stress test, this oxygen exchange issue and why people are short of breath with conditions like long COVID. So they're short of breath despite the fact that their chest x-ray looks good and their lung CT is clear, because it's not the organs themselves, it's the oxygen exchange. And so there's actual mitochondrial dysfunction where the cells cannot take in and convert enough oxygen. And these people are not getting full oxygen, full blood return up to their right ventricle, to fill up their right ventricle, to disperse more blood. So it's a kind of a vicious cycle of cells not having enough oxygen, blood not returning up to the heart, and it not being perfused with enough oxygen. And that can lead to hypoxia in multiple body systems, including the brain.
Yeah, and so for those people who aren't familiar with POTS, can you just tell us what that is?
Yes, so POTS stands for postural orthostatic tachycardia syndrome. It's a little bit different from dysautonomia, but they fall under the same umbrella. For postural orthostatic tachycardia syndrome, when a person changes position or moves position, blood drops. And so the vasculature of the body is not tight enough and taut enough to hold blood in their core. And so with changes in positioning, they get pooling in their extremities. They'll, if you think about it, we've got about 2 or 3 liters of blood that would fall with gravity to our legs when we stand up. If not for our vascular system, which tightens everything up, the muscles tighten up, everything moves seamlessly to hold blood in your core and to keep the blood where it needs to be. And so with POTS, the blood drops out. They can become dizzy and orthostatic and have blood pressure issues and fainting episodes. Dysautonomia is interesting because this is more with the autonomic nervous system of the brain. And what we're finding with long COVID is the dysautonomia is not damage to the autonomic nervous system itself, but rather it's the autonomic nervous system responding to the oxygen exchange issues. And so as SLPs, you know that our autonomic nervous system is 2 parts. It's our parasympathetic nervous system that is essentially the bus driver that's driving the bus. And when you need to move and get bursts of energy and reach and pull and do everything that you need to do, that part of the brain is telling your body where to direct blood, which muscles to use, managing your blood pressure and your respiratory rate and your heart rate to keep you in homeostasis. And then we have the sympathetic nervous system, which is the alert passenger that grabs the steering wheel of the bus when a child darts into the road. And that's your fight or flight. And that takes over when you need to move quickly and you need to move blood through your system rapidly. And so the autonomic nervous system is locked in the on position in these cases. The warning lights are constantly going on. And so that contributes to the heart palpitations that people get and the chest tightness and the difficulty breathing and GI issues and skeletal muscle issues because blood is pulled away from anything that the brain deems non-essential at that moment and towards the heart and the lungs and the brain. And that's debilitating as well.
Yeah, and I mean, and on my end, it's fascinating, again, because I'm teaching this TBI class, and so I needed you like 2 weeks ago to explain that, because when I explained the parasympathetic and the sympathetic nervous system, the students are all kind of like,
Yeah.
just looking at me like, okay, lady. So I like that you gave that example, because I think that is, especially for the sympathetic, the alert passenger who grabs the wheel, that fight or flight is what I describe the fight or flight as. You know, you're either going to sit around and wait and see what happens, or you're going to flee the area.
Mm-hmm.
And I think it's good to have those concrete examples. And again, when we relate that back to what we know as SLPs about hypoxia and how we've seen that in the past with things like ICU delirium, or, you know, these post-cognitive changes for people who've had these long-term ICU stays, it makes complete sense. And I think the big difference is, even though the fatigue does happen from a physical standpoint, I think we're seeing it more from the cognitive standpoint. And when it's someone who's been in ICU, you might see both. But then in a TBI patient, you might see someone who physically, they've recovered great. They've done really well. They're basically back to their norm when it comes to physical components. And so I think it really speaks to our understanding of how the brain works. And like you said, that whole oxygenated blood exchange, and there's just so much, I think, out there to learn.
Yeah. So the researcher at Harvard who's also working through PolyBio is Michael Alcazar, and he's doing very high level neuroimaging of the brain using an fMRI and MRI PET scan combo. And I'm excited because I'm actually going to be able to be a healthy control for that study.
Oh, that's cool.
Which I'm very excited about. I always try to participate in trials since we have so many here and studies here, and anything I can do to further long COVID research and get a free MRI out of the deal. But it's really interesting. And he's looking at the glial activation in fatigue and how people who have chronic Lyme, chronic fatigue, and long COVID, how their brain activates in different ways than brains that are well.
Okay. So when they're doing the fMRI, are they doing more of like a cognitive task or a language-based task, or is it kind of all of the above?
Both. It's going to be about 90 minutes. And so first they'll do a DNA profile. I sent in my saliva sample, and then they'll take blood and urine and more saliva. And then it will take about 90 minutes to do the full PET MRI, and they'll have me do a cognitive task during portions of it.
Wow, that's really good. And I know that there's been a ton of research that's come out of Europe, and even there was a lot that came out in the Middle East kind of early on, which, I mean, I found kind of surprising, I guess, because I think I don't know, you get kind of pigeonholed, I think, when you're, especially during that time when we were so isolated from various groups, you know, our social, our work and all that. And you sort of think as the governmental agencies or even the privately funded research is coming out of the US, but sometimes that's not true, that a lot of it is really across the globe. It's not just US studies, it's partnerships with other agencies in Europe and in other countries. So did you have any experience or have any kind of those pivotal studies that are part of what you've looked at?
Yeah, definitely. And that's a great point, that it is a worldwide effort. And so the large initiative coming out of the US, and we're certainly the country that's doing the most research, is RECOVER, which is researching to enhance COVID recovery. And that's an NIH initiative with the understanding this is a novel virus. And so instead of having all of these researchers from everywhere in a silo doing their own research, this is a large coordinated effort to understand COVID. And so it's several parts. And one is they've amassed a biobank of over 15,000 patients' biological samples, and those have been drilled down to everything, DNA, gene expression, everything like that. And then within those, there's an autopsy study that's based out of Mass General, provided a lot of that. Maternal medicine, there's a bank for that, pediatric COVID, long COVID. And so that's a database that's available to researchers throughout the US and I think the world as well. They've made it public knowledge so that everyone can access that information. And then they're running clinical trials throughout the country using target locations so that everybody is represented. And so they've had a couple of big clinical trials that have come out, and there'll be about 70 locations around the country to represent everyone who's living with long COVID. And then those inform smaller studies, and the smaller studies inform the larger studies. And so it really is a coordinated effort throughout the United States and the world. And there's a lot of research going on in other countries, and it's interesting, it's kind of specific. It's interesting that Germany is doing a lot with fatigue and developing some novel medications. Hong Kong and Singapore are doing a lot of great research, and they're doing a lot of research on, again, novel medications that were not FDA approved here, but they can use there. And they're looking a lot at anosmia, which is loss of taste and smell. Spain has some really good, and Brazil have some really good studies on fatigue. And so it's definitely a collaborative effort.
Yeah, and I've been kind of following, I'm sure not as closely because that's your job, but I've tried to follow along with some of the ones that I see that are the bigger ones that come out, because of course, the more longitudinal data that we have, the better we can be prepared for what we might continue to see. Like you said, as these variants continue and people continue to get ill, and they've had it across multiple times. And I just had something kind of pop in my head, because I know a lot of people have said, well, I didn't get tested because I just thought it was the flu. It could have been COVID. The symptoms are the same, which for me, they were not. They were similar, but not the same. Have they done studies to sort of delineate those symptoms or those post effects of like someone who had influenza versus COVID that was a little bit more long lasting? Do you know of any studies with that?
There are very few cases of long flu. It does
that's what
happen,
I thought.
but it's not one of those illnesses that's associated with that. The immune system can pretty well tackle the flu. With long COVID, the people who have very severe COVID are more at risk for long COVID. But so many people have mild to moderate COVID, and so those are huge numbers as well. So it's not really a fair comparison to look at those two, because you're still at widespread risk with mild to moderate COVID. A lot of our patients have had mild cases, and in many cases, asymptomatic cases. Mm-hmm. What happens with COVID is either it's very different than acute COVID. So you won't have the runny nose and the fever and things like that. It's some people completely get well, and then after a few weeks, the virus has settled into your system, and then it starts doing its second wave of damage. For other people, they started off with fatigue and heart palpitations and headaches with their active COVID, and it just never resolved. We do also know that COVID can flare. It can wax and wane. And so when you are exposed to other viruses and other illnesses, and your immune system again gets, fired up, then it can spark another bout of feeling really ill with long COVID symptoms or COVID symptoms. And so it's not relaxing, remitting like MS, but there are periods of where it may worsen.
Wow.
Some of the symptoms associated with long COVID that they've tried to figure out, people who have acute COVID, what are the symptoms that lead more likely to long COVID? And GI symptoms is one of them. People have severe GI upset, and there's a lot of work going on right now about the gut biome and the messaging between the brain and digestion. as being as a major area of communication with long COVID. So that is one. Severe brain fog is another. So if you have a lot of neuro symptoms, but it's not a clear cut, it's definitely not predictive.
I might need to come up and see you
Yeah.
because that's, I mean, it's very interesting to me because of the first time I had a lot of GI symptoms, and my husband and I were sick at the same time, and he didn't have any GI symptoms, and he was done fine way before I was. And the same thing the second time I had a lot of GI issues that he didn't have the second time he had it. He was basically like, "Oh, I'll take a nap and I feel better." And 3 days later, he was like, "Oh, I'm good. I'll go mow the lawn." And I'm like, 3 days in, I'm like dying.
Yeah. There's a question in the chat about whether hyperbaric oxygen therapy is used for long COVID, and yes. So there's a couple of studies going on right now for hyperbaric oxygen, both for fatigue and for brain fog.
Mhm.
We have a place up here that's also doing some independent research using hyperbaric oxygen therapy with long COVID, and then plans to publish that. The challenge is that it's not FDA approved. It's only FDA approved for certain conditions like wound care, and it's
Mhm.
cost prohibitive for a lot of patients to be able to do. And so it needs to be in the context of probably clinical trials to get enough people to really look objectively at it. But there's at least 2 clinical trials going on right now for hyperbaric training oxygen.
And so just kind of continuing on with that research studies, because I know we kind of talked about this earlier too, that there's a lot going on. What are some ways that people, like if you're an SLP or an audiologist and you have patients that you want to refer or at least give more information to them about these ongoing studies? Because I know a lot of them are looking for participants. Where would we go look for that?
2 good places to look. One is Recover, the
Mhm.
NIH Recover, which I think is recover.org. I believe that's the
Mhm.
website. And that links to all of their active clinical trials. And so we just finished, they just finished a big clinical trial using an extended course of Paxlovid to
Mhm.
see if a longer course of Paxlovid, in this case, 15 days or 25 days, can help clear viral remnants and help alleviate long COVID symptoms. There was a study that came out of Stanford that found that it wasn't effective, but that was a much more limited study than this one. That study, I think, had 100 patients, maybe 150, and we're looking at patient-reported outcomes of general symptoms. This is 900 patients from across the country, and it's looking at 3 different symptom clusters. It's looking at exercise intolerance and fatigue as one, cognitive dysfunction as another, and autonomic dysfunction as another, and including a lot more biologics and sampling and objective measures. And so that study just concluded. The next 2 studies that are coming out are Recover Autonomic, which is trialing 2 different treatments for autonomic dysfunction, and Recover Sleep, which is a kind of a multimodal platform with there's 4 to 8 combinations of therapies that people can get for hypersomnia and for disrupted sleep. The
That's
other place to look, so recover.org is one. The other place is clinicaltrials.gov.
Mhm.
And that's my go-to, and that will give you countries from around, to studies from around the country and around the world, and will capture a lot of the hospital-based studies. And so you could just do the search term long COVID in your area and see what's available.
And that's an area that we didn't touch on, but I had it in my brain. And this to me has got me really thinking. So I'm glad you circled back to the sleep dysregulation. Can you talk about that for a couple of minutes?
Yes. And so that's been another primary symptom of long COVID, and it manifests as hypersomnia or fatigue, where people need to sleep a lot more. Their sleep is not restful. They need to take naps during the day, and sleep is just not having the restorative properties that it needs to have. And then other people report disrupted sleep. So they might be able to get to sleep, but they're waking up multiple times a night, or they're having nightmares, or they wake up their heart pounding. And so it's getting to sleep and staying asleep, and the quality of their sleep as well. And so those are the 2 areas of sleep that are most affected. And that really just as you know, we've all been, when you're sleep deprived, that colors everything and it makes
Mhm.
everything worse. And so if people can get some relief in that area, then it also can help with fatigue and with the depression and anxiety and the cognitive symptoms that come from long COVID. So that's a big area of concern.
Yeah, and it makes a lot of sense again when you're looking at how your brain functions and everything is interrelated. And if you've got some area that's not responding well or not responding the way that it did before your illness, of course, it makes sense that you may have this sort of long lasting and long ranging impact from the cognitive piece to the sleep piece. So we know that sleep deprivation or sleep, like you said, disordered sleep, if for those people who've had children, that you don't sleep for like, I don't know, months.
Yeah. We do recommend for people too, there isn't a test yet for long COVID. There aren't biomarkers identified yet. That's coming. It's in the research stages. But a lot of the long COVID workup is ruling out other treatable conditions. And
Hmm.
so checking their labs to see if they have an iron deficiency or vitamin deficiency and can that be restored to help. Looking at their sleep and doing a sleep study to see if there's something that can be helped with that. Assessing their cardiovascular function and seeing a pulmonologist and a cardiologist. So in many cases, it's a diagnosis of exclusion that we've ruled out other organic causes for these symptoms and now we're left with long COVID. So it is important to try to treat what you can. And right
Yeah.
now, we're still in the stage of treating the symptoms of COVID and not the root cause. And that will be coming. And it looks like the direction that research is going is it will probably be with anti-inflammatories and immunotherapies.
Oh, wow. Yeah. Well, and I know one of my colleagues at work mentioned, because she just had COVID and she took Paxlovid, and she said that her PCP told her if you take Paxlovid, you can only take it the one time that if you get infected again, you can't take it ever again.
Well, that's completely false.
That's what I thought.
Completely
When
false.
she said
And
it,
very
I sat there
discouraging
like,
to hear that. Very discouraging to hear that. No, you absolutely, maybe the insurance company wouldn't pay for, right away, but Pfizer has tested Paxlovid extensively and it is safe for 5 days, 10 days, 15 and 25 for our clinical trial purposes. We do know that 5 days is not long enough for a lot of people because about 20% of people who take Paxlovid get rebound. And so I think they need to look at longer doses of Paxlovid. Pfizer's also coming out with a new antiviral that will replace Paxlovid. So Paxlovid is ritonavir, which is a boosting agent, and nirmatrelvir, which is the antiviral. And so nirmatrelvir does the work and ritonavir acts to keep it in your system as long as possible so that it can do its work. Ritonavir is the part of Paxlovid that gives you the terrible taste in your mouth and also causes the liver and kidney risks and the medication interactions. So this new antiviral will not need a boosting agent. It will be one pill and it won't have the toxicity concerns for your liver and kidneys and the bad taste. And so that's in phase 2 or 3 clinical trials now. And so that will be coming out to replace it. But I think it's people should always advocate for Paxlovid. It's approved for people over the age of 12. We're not, in other countries have a hard time getting it. We don't. There is no shortage of Paxlovid. So ask for it and get it. You want to get that virus out of your system. Even if you think, I don't feel too bad, get it out of your system. Don't let it dig in and get comfortable. So
yeah,
that's my advice. And to be a squeaky wheel when it comes to COVID care.
yeah. Oh my goodness. One other thing I wanted to ask you about, was there any particular case studies for you? I know your role is a little bit different as the director, but have you had any of your team come to you with maybe some challenging cases from an SLP standpoint where they were really having trouble with assessment or treatment or response to treatment?
We have had, so what we do is we have a pretty large network of SLPs, of outpatient clinical centers, and we have some that are a little more long COVID designated. And so we do hear back from them. The cases themselves are not puzzling. Sometimes the neurological symptoms are. Some patients really present with neuroinflammatory issues. or issues that seem really extreme and they need more of a neuropsych workup or neuropsychiatric workup for that. And so generally the SLPs, I think, are well positioned and pretty savvy with
Yeah.
treating patients. The things that they come back to us to ask about are for further neurological workups or help with disability, with helping advocate for their patients for short-term and long-term disability claims.
Oh, that's a really good point too, because I know we had someone that I worked with before whose husband was much younger, like early 30s, and wound up doing a short-term disability because of his long COVID. Are we seeing an increase in those claims?
Huge increase. There's a huge increase, and it has been approved by the ADA as a disability. It's a real challenge for people to get disability because it's still poorly understood. And so a
Mhm.
lot of people apply 2 or 3 times before they can get Social Security disability. And that's a great area of need in the long COVID community, is social workers to help with that process and for, better disability advocacy and work accommodations.
Mhm. Yeah, and I think that's, again, when we think, so, my dad had a stroke in the mid to late 90s, and the first time he was young, it was 47, and the first time that he went for disability, it was the same kind of situation where he went and they declined or denied his disability because they thought he looked okay. But my dad had right hemiparesis. At that point, he was still walking with a cane. He had dysphagia. He had aphasia. I mean, he was not going to be able to go back and do his job. And I remember the judge saying, you could be a greeter at Walmart. And it was like somebody had just taken, like he had just taken a slap to the face. It was unbelievable back then for a stroke that was so debilitating. And so I think when we're thinking of it in those terms, that there's some hope here that people can become more educated, learn more about the research, have that backup from the social working team. And the neuropsychologist plays a big deal in that as well.
Right. And that's a big area of need, is psychiatry and mental health resources is very, most of our patients, they don't want to stop working. They may
Yeah.
need short-term disability to take what we call a period of radical rest. Like, you got to take a break from all of the stresses and rest and see if you can kind of get yourself reset and then add activities on and pace them according to your abilities. And many want to work, but they just want accommodations, to the ability to work remote or the ability to use some family medical leave for medical appointments and things like that. So I think the good thing is that the long COVID community they are the productive group of society. And so they are tremendous advocates for themselves. And in most cases, they know more about long COVID than the providers that they're seeing. And so they're
Mm-hmm.
able to drive a lot of change and really need to be at the table with decision making when it comes to long COVID, because this is not a group that wants to be disabled. This is a group that wants answers and they want to be working.
Yeah, for sure. There's a question in the chat. Is the study clinical trial about which you were speaking, the encetralvir for viral persistent inflammation in people experiencing long COVID, the PREVAIL/LC or -LC? I think that
Yes. So
clinical,
this is an immunotherapy that they're doing at the University of California at San Francisco. And they're doing a tremendous research there. And that is, I believe it's an infusion. It's an immunotherapy infusion.
yeah, and the clinicaltrials.gov, I think, was just the place that Julie was saying to go and see what kind of studies there are out there. But yeah, that's a good one.
That group, and so that group includes Michael Peluso, who's an infectious disease doctor. And so many of these doctors are HIV specialists who've now pivoted to this viral illness. And so he's working both with Recover and then also with Polybio, the private consortium.
Yeah. And I'm thinking back to like the SLP part about what you said, that because I think we're treating a lot of these patients very similarly to our patients who had things like post-concussion or mild TBI. Are we also, and I think you touched on sensory a little bit, but are we seeing things like hyperacusis and photophobia, or is it more
Yes.
generalized?
Hyperacusis, photophobia, tinnitus, there's a lot of that. There's also people who have voice disorders and disordered breathing, and so breath work can be helpful with that. Rarely they have dysphagia, but rarely. But
Mhm.
some of them really have some interesting, strange GI symptoms, and the virus, which we know goes through the nasopharynx, stays there, and they have chronic ENT issues as well. So it can run the gamut for sure. And then it also can lead to hypercoagulability and strokes. And so we've got a number of people who have had that happen to them as well and have aphasia.
Wow. Yeah, it's really eye-opening. Again, I just kind of astounded myself because I thought I knew it a lot, but I didn't know enough.
Well, you're in good company, Renee. Most people don't, which is why I'm shouting it from the rooftops. Don't let this happen to you. Yeah, it's a really chronic and widespread condition, and I think a lot of people have long COVID and they are not aware of it. They just know that they've never felt right since. And so
Mhm.
those folks, have to be really careful with recurrent infections. Because if it's taking you a long time to recover from a COVID infection and you're not feeling well, and you still are apt to shortness of breath and can't exercise like you used to, you risk worsening it with future infections.
Wow. Mm. Well, I might have to be masking everywhere I go this fall because I'm not I'm not feeling it. I don't want to do that again.
I know none of us want to, but trust me, you don't want long COVID even more.
Right. No, I
And it
don't
can be
want.
used judiciously. Use it when you're in crowded situations and you're walking through crowds and things like that. And keep
Yeah.
up with the COVID boost, the COVID immunizations and vaccines. Everyone was
Yeah,
crying
and that's
this new wave. Not many people got the Omicron booster last fall and have been with the wave right now is huge, and it's not even as it's huge that we know of, and it's even bigger because people aren't testing and they aren't quarantining, and they're saying it's just allergies, it's just a cold, and it may not be.
yeah. Well, this was really, really eye-opening and very helpful. And so I really appreciate your expertise and your willingness to come on and share what you know. And definitely have to keep in touch and maybe get an update in 6 months to a year and kind of see where the research leads and what that looks like and where we're at. And hopefully we can kind of keep these numbers going in the opposite direction instead of going up, going down, so that
Right.
we don't have to keep seeing these patients suffer because it's tremendous.
It is, it is. And my one last point with SLPs, just to quickly say, with the fatigue, we're finding that telehealth services, if you're able to do that in your practice, is really helpful for these people to be able to provide virtual visits or
Hmm.
telehealth visits for SLPs. We try to do that when possible because of their fatigue level and difficulty getting to and from, outpatient locations, and also a lot of them have a big fear of being reinfected in medical
Yeah,
environments.
yeah, no, that's great. Both valid, really valid points, and certainly considerations for us as we try to advocate for keeping telehealth available to us too. So thank you for that. I appreciate that. So thank you again for being here. This was great, and I wish you all the best. I appreciate your research because it's really, really interesting and
Thanks for
really
having me.
necessary.
I'd love to come back. The research is moving fast and furious, so there'll be changes, a lot to talk about, even 6 months and a year for sure.
Okay. Well, that sounds great to me. Thank you again, Julie, and we look forward to seeing you again.
Thanks, Renee.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use Brainstorms20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms, Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.